Welcome back. My next guest is Dr. KaraBeth Moore, who is a breast surgeon with the Lexington Clinic. Welcome.
Thank you for having me, Dr. Fox. Really appreciate you being here.
Now, I said breast surgeon, so one of the main things you talk about and treat is breast cancer.
That's correct.
So,
yes.
You know, you got your pink on. I forgot to wear mine because October is Breast Cancer Awareness Month. Are you seeing more breast cancer?
October always brings women to get their screening mammogram because there's a lot of promotions that go on in the community. We do that. All the hospitals in the town do community outreach to try to encourage women to get their screening mammogram starting at age 40 and then continuing on. So we do get a surge of women that come to get their screening mammogram in October. So really the diagnosis starts then, and then really we get really busy after October, all the way through February usually.
Now you mentioned age 40. Is that standard for everybody? Is there a specific person that should get a mammogram?
Yeah, so anyone that's an average risk woman needs to get a mammogram starting at age 40 and then get a mammogram every year thereafter. And now if you're at a high risk, then we need to starting to do imaging earlier than 40.
Now you mentioned imaging, there's mammogram, but you do also a lot of other things in terms of looking for breast cancer or at breast cancer.
Yes. So just a standard mammogram, usually we use three-dimensional mammography to do screening mammogram of women, but we also use ultrasound, we use contrast mammogram at the Lexington Clinic. We're the only place that does that. We use that for women with dense breast, intermediate risk, and sometimes even high-risk patients, and we use breast MRI as well.
How do you know what to pick?
That's a good question. Usually just ordering a standard mammogram is what most family practitioners, OBGYNs should be ordering, and then we decide if they need to have something more like a contrast imaging or something like that. We have a high-risk program where we see all women that have intermediate or high risk, family history, a genetic mutation, those kinds of things.
Now you mentioned risk. Who is at risk for breast cancer?
Well, just being a woman, you're at risk. You have a 1 in 8 chance of getting breast cancer if you're a woman. And
but that's not all. Women are not the only ones that get breast cancer, too.
That's true, but male breast cancer is much more rare. Yes.
So who else? What other factors might there be
to increase the risk? So 1 in 8 women get it, but then you can increase your risk if you have early menses or you don't have children. As we get older, we have a higher chance of getting breast cancer. So actually, most breast cancers happen in women that are over 65. If you have a family history, that's a big part. So if your mother, your aunts, first cousins, things like that have had breast or ovarian cancer, that's a big risk factor. If you've had a male in your family that's had breast cancer, that's a big risk factor for having even a genetic mutation.
Now you mentioned genetic mutation. Tell us a little bit about that.
So there's many genes that we can check for. The one that most people have heard of is BRCA1 and 2, also called BRCA. That one carries with it the highest risk of developing breast cancer in your lifetime, as high as 85% if you're BRCA1. But there's all kinds of other genes that we also test for now, CHEK2, ATM. And so we have a program at the clinic where we can do genetic evaluation and genetic testing if you qualify.
You mentioned a program at the clinic. You have a specific breast cancer team, I guess.
We do. We have a multidisciplinary team, and we have a team of all women in our breast care center. We have a breast radiologist, Dr. Callahan. I have a nurse practitioner, Jessica Shork, who runs our high-risk clinic and our survivorship program and also does genetic evaluation and testing. And then all of our man-techs are women, and yes, we just try to take care of women with, with women.
And surgery is one option, and you are a breast surgeon. Tell me a little bit about the surgeon, and then one of the side effects of the surgery is lymphedema, and that's one of your specialties also.
Yes, so lymphedema is definitely something that we like to try to identify and prevent early. So if a patient is getting breast cancer treatment, they can potentially be at risk for developing lymphedema. So when I do breast surgery, some women have to have lymph nodes removed in order to stage or to treat their breast cancer. So that can put them at risk of developing lymphedema. Lymphedema is swelling in the arm on the affected side. Also, radiation and chemotherapy can increase those risks. So we have a screening program where each patient, that before they get any treatment, they get measured on, it's called a bioimpedance spectroscopy. So it measures the amount of fluid between the fat cells. And we get a baseline before they get any treatment, and then when they come back for their subsequent visits, we measure them, and we can detect lymphedema before it becomes an actual symptomatic problem for the patient, and then we can get them into physical therapy and hopefully prevent it from progressing into chronic problem.
You also mentioned just briefly, you do the surgery, but sometimes there is follow-up chemo or radiation depending on the results of that.
Yes, so each patient we treat individually. Some patients need only surgery. Some patients need surgery and chemotherapy and radiation. So we have a multidisciplinary approach where every patient, we talk about them in a multidisciplinary breast conference and decide what treatment they're going to need and get them in to see the specialist as we feel like they need it.
We appreciate you coming in. You do the whole gamut from diagnosis to the end and follow through, and we appreciate all you do.
I appreciate that. Thank you.
All righty.
Thanks for having me.
We'll be right back.